Good morning, everybody. Thank you so much for joining us. Welcome to the webinar from the Alliance, Finding the Solution in High-Value Care. I'm Catherine McLeod, Manager, Product Portfolio and Strategy for the Alliance. We're pleased to have Dr. Michael Tuggy with us this morning to talk about how primary care can be different than what it is today. That difference can move healthcare forward by controlling costs, improving quality, and engaging people in their health. Before we get started, let's go over a few housekeeping items. If you have any issues during the webinar, please feel free to use the question box to communicate with us. We will have time for questions at the end. To ask a question, you can either use the questions box and submit it that way, and we'll save those for the end. Or at the end of Dr. Tuggy's presentation, if you'd like to ask a question, just use the raise the hand option, and we'll unmute you to ask your question. And just a reminder, during the webinar, you are on mute. And after we unmute you, just remember to unmute yourself before asking your question. Let's introduce you to Dr. Tuggy. Dr. Tuggy is a clinical professor at the University of Washington School of Medicine and a practicing rural family medicine physician. He was the director of the Swedish Family Medicine First Hill residency for 14 years, where he practiced full-spectrum family medicine. Dr. Tuggy is also a member of the American Academy of Family Physicians and the Association of Family Medicine Residency Directors, which he led as president in 2013. From that leadership position, he joined in on the development of the strategic plan for family medicine that is now being implemented by Family Medicine for America's Health, where Dr. Tuggy is the vice chair of the board. I will now turn the presentation over to Dr. Tuggy.
Good morning. It's a pleasure to be with you all today, and I'm looking forward to sharing some ideas with you, and then also having some time to take some questions and discuss about how do we increase the value of primary care that you and your employees hope to receive in the future. So the key points is what I always like to start out with is to have the learners understand what is it we're really trying to get across today. And the first key point is that fee-for-service creates incentives that are really adverse to value. And this has been a challenge for primary care for years now, that we've had incentives that really do not allow us to look at value, but really more at volume. The other thing is that understanding what happens at the micro level at every visit is key to finding value. And then finally, we can describe how a comprehensive primary care payment model changes these incentives to allow for high value care. And we'll touch on that today, but we'll also, with the next webinar, spend more time on how this really changes that dynamic. So for fee-for-service, fee-for-service rewards throughput and procedures. I think this is the key takeaway about what is wrong with our current system. We are paid on volume, and every provider of primary care knows that the more patients they see, the more their operations are sustainable and the more they may earn personally. And same thing with procedures. And this is true across the entire system, not just across primary care, but for every physician who works on a fee-for-service basis. Typically, the insurance plans that we work with reimburse primary care at about 4 to 7% of the total cost of care that goes to primary care services. And the challenge with this is that this is a remarkably small amount of resources of healthcare dollars that are actually going to the primary care service level. But this is the way that we've designed our system in our country. Aside from that, we have 8 to 10% of our collections that occur at the primary care office that go off just to go to billing services. And on top of that as well, about 18 to 20% of the total cost of care that we currently have in our current model goes to take care of claims administration. So there's a significant whittling down of resources and funds that are provided at the primary care level. And what happens is this results in a under-supported, a strained, and partially effective primary care system that we have currently designed with our healthcare model that we use in this country. So how does payment affect the way we practice? As I mentioned before, fee-for-service is basically survival by throughput. If you don't see enough patients during the day, you cannot keep your clinic open at the primary care level. And there are many practices that would not be open if they weren't sustained by another part of the healthcare system, such as a hospital or perhaps a multi-specialty group or something like that that brings in additional funds or other shared savings types of agreements. The total amount of visits are really the measure of what your value is to the system. Doing things to patients, such as procedures, getting x-rays and other radiology studies, doing labs, all those things improve the reimbursement to your system that you work under. Only face-to-face encounters actually count. So anything that we do on the phone, anything we may be doing in trying to improve population health, that would be outside of an office, there's absolutely no reimbursement for that in the fee-for-service model. Sadly, in the reality is for payment that outcomes don't matter at all. We are not reimbursed for good care or bad care. Whatever care we provide, we are reimbursed the same amount, and there's no quality kind of metric that's being used in the fee-for-service model that's been a reliable way of being paid. And the final thing is that we're not actually responsible for the patient outside the office visit. There's really no sense in the fee-for-service model that what happens to the patients after they leave your door is your responsibility at all. And so every bit of that care that we do is very reactive. It's only reacting to patients who come in, and patients who may not come in, who may need to come in, are not addressed at all in this model. If you zoom in even closer, what happens on a day-to-day working schedule for most primary care practitioners is that typically we may see about 20 patients per day. And in that 20 patients per day model, the face-to-face time we often have with our patients is compressed to about 8 to 10 minutes. And I know that many of you have seen your primary care physicians, and you've had probably a wide range of variable experiences to reflect on. But 8 to 10 minutes for a lot of people when they come in maybe once a year and they have multiple concerns that they need to share with their provider, or if they have complex medical conditions, this is an extremely short amount of time to get things done. And as a result, what commonly happens is that we order tests and studies, and we also may refer people out when we don't really have a lot of information because we haven't had the time to actually gather that information. So what happens when you look at the length of visits versus the accuracy of diagnosis, there's actually quite a drop in accuracy the shorter the amount of time that we spend with patients. And this is true across many specialties. Many of you may have had a colonoscopy done by a GI physician, and typically now they have to, in their notes, dictate how much time they spent looking at the colon as they were coming out to look for polyps or cancers. And the reason why that's being done is that there have been studies that show that the amount of time they spend tied directly to how accurate they are with finding these things. And it's very true, too, in primary care, that the more time we spend with patients, the more benefits we get as far as accuracy and also gaining the trust of the patient as well. So this impact of the high throughput is to have more tests being ordered, more radiology studies, and oftentimes I've seen cases where the wrong studies have been ordered because of not really understanding what the patient's complaints were thoroughly. So we may order an MRI or a CT scan that maybe not be the proper study for what the patient's complaints are. And there's more referrals. When looking at some studies, looking at how family physicians work versus their affiliated counterparts, like the nurse practitioners and PAs, they may refer less, but they still refer more in a fee-for-service model than they do in a value-based model as far as sending patients out for referral to get clarity about the diagnosis for a patient. The other thing is that procedures take time, and so many primary care practitioners do not have time built in their schedule to do procedures for patients that need to be done at the primary care level. And so this lack of time and lack of incentive, because their incentive is to see more patients, makes it difficult to do procedures at the primary care level unless you really build your practice around that model. I just want to show you just a case example. This happened actually about 2 months ago in my practice, where I saw a patient who's 72 who came in with some flank pain, and he was having pain when he was urinating, and he had a history of kidney stones about 15 years ago, and he had a history of a large prostate. My medical assistant obtained a urinalysis for me before I went to see the patient, and there was blood in his urine. And right away, with his story of kidney stones, blood in his urine, and flank pain, it just seemed that a kidney stone was very, very, very much likely the diagnosis. And so as I was talking to the patient about this, we talked about straining his urine and getting him on antibiotics because he may have a bladder infection on top of the stone. And that was the initial plan. But I actually had more time with the patient, so I went back and just reviewed his pain story a little bit. And we actually, as we were discussing it, his pain wasn't really intermittent, it was a constant ache. And kidney stones pains come in waves. And as we were talking about it, he said actually the pain will go away maybe 50%, but actually hangs around all the time. And that is not typical of a kidney stone. It had been going on now for several weeks, not just a few days at the intensity he was complaining of. And so in exploring his history further, I found that he really did not fit a kidney stone story very well at all. So I ordered a CT scan of his abdomen to look at his kidneys, and we found a 5-centimeter renal cell carcinoma on his kidney with no metastases. And 10 days later, he had curative surgery with having his kidney removed, and he no longer has renal cell cancer. This is the type of thing that happens very often at the primary care level if we are accurate with diagnoses, and the amount of cost savings. If you just think about, had we treated this as a kidney stone, let the tumor grow for months longer without getting further studies at this time, he may have had metastatic renal cell cancer, and the cost of care for him would have been astronomical compared to having the nephrectomy, which was still expensive, but far less than trying to treat a metastatic renal cell cancer. So what happens if you lengthen the visits? The first thing is that we have better communication and understanding between the patient and provider. And in the practices that I've seen that have moved to a value-based model, the degree of trust that develops between patients and their providers when they have more time is really remarkable. And I see this with patients who I have seen who come to our practice, where as I talk to them about their previous care that they've had, oftentimes it's pretty evident that they have felt incredibly rushed through their visits they've had, and they really did not feel like they had a relationship or trust with the provider they had before. And many of them comment that having more time has made a big difference, and they feel like they're being heard, which is obviously key to all of us when we're trying to explain what symptoms are to a provider of healthcare. So with greater trust and greater time, we get greater diagnostic accuracy. And also with more time, if we need to do things like simple office procedures, we can build that into our schedule much more easily. And what has happened with many of these practices, and it happened with one of our pilot practices that we did where we use a direct primary care model, which we'll talk about later, in payment, is that we actually have a significant reduction in the total cost of care, ranging from 15 to 30% in 2 of the pilots that we set up in Seattle. And obviously these are big numbers. When you start thinking about a 15 or 20 or 25% reduction in your total cost of care, that's a fairly stark contrast to what most people are doing these days, where their cost of care continually increases every year and their premiums are going up year after year because of the cost of care going up for their patients and their employees. So if you think about how do we change the dynamic of what happens in the office, again, in order to get better value out of what we do, in order to actually lengthen appointments, you either have to earn more per appointment, so find a way to get more money from a payer per appointment, or you have to eliminate payment per appointment. Just get rid of that entire system where you're being paid on how many patients that you see that day. If we manage, if you're going to manage a population of patients, you would need to use a team approach, it actually to take care of patients if you're not actually able to see more patients during the day, or if you're trying to see less patients during the day, you're going to have to find a way to take care of other patients without having to have them be seen. And neither of these two models are supported with fee-for-service. There's no way to manage a population of patients and see less of them if you can't use your team members, unless you have an alternative way of taking care of patients besides face-to-face visits. So this leads us to comprehensive primary care payment. This is the model that we have been exploring over the last actually about 10 years in different pilots across the country in primary care. And it's been done in variable ways, but this is a really key aspect of how we're seeing the change in primary care delivery really improve as payment models change. The incentives for comprehensive primary care are really based on the total population. Basically, everyone in your population matters. Whether they're in the office or not, you're responsible for the care that is being delivered to a population of patients with this type of payment model. Patient contact in any form is allowed by the team, and also it's really rewarded by this model, so that if a patient wants to ask a question by email or by phone, or even set up a phone visit and have blocked out time to talk to their provider without leaving the workplace, that can be done. And we had incredible reception to this in our clinic in Seattle, where we set up our direct primary care model, where patients many times were self-employed, and they would much rather just call in for 15 minutes and go over their diabetes and their blood sugars and talk to their provider without having to leave the office, and save them a tremendous amount of time in driving, parking, checking in, all those kinds of things that happen at a clinic that typically take more time away from the actual time with their provider. The other thing is that the care can be delivered and extended by the primary care team. There are some times where patients come in and all they need to do is have perhaps a lab drawn and results done. A good example is patients who are on blood thinners. They can come in and get their blood tested to see how thin their blood is. They can leave. We can call them back, have them adjust the dose of their medications based on their tests without having to have them see a provider. And it saves them time. It saves us time. It doesn't require that we actually see the patient for some of those simple things like that don't require face-to-face care. Same thing with treating bladder infections and other types of things that don't require necessarily a physician or nurse practitioner or PA to see the patient. So alternative visits are encouraged, again, using messaging systems or phone visits can be done with this type of payment model. And then the other thing is that patient experience really matters. If we had a system where patients would be enrolled in clinics and enrolled under a primary care provider of their choosing, if that service is poor, that patient can walk and go somewhere else. And if somebody is consistently providing poor service over time, their patients are going to suffer, both in the clinical side as far as their health, but also they're going to leave. They're going to find somebody else who takes care of them better, that they have a better relationship and better trust with. And so it serves the practice well to really serve their patients well in this type of model. With this model, too, there's a 24/7 accountability, and this means that the clinic systems have to provide a way for patients to get access to healthcare advice after the clinic is closed, so that they can be connected to their team and reconnected with their team the following day if something happens after hours. So we expect clinics that are operating in a comprehensive primary care model to provide some sort of access to their providers, or at least support through a nurse practitioner call line or something like that in the evenings and overnight. And finally, with this model, you can actually set up the system where outcomes do matter. You can actually adjust the payment model to the practice based on the outcomes of their patients. The best thing about this care is it actually allows for proactive care. In this model, you are rewarded for thinking ahead about what patients need, getting them in the office if they're not showing up for their appointments, making sure they have their health screenings done, all of those things pay off because all of those things will reduce the long-term total cost of care for a patient population. So what does this look like in practice? What we saw in our practice was that we had a significant reduction in the requests of patients to be seen in the clinic when they realized they had other options. And you can almost knock out 30% of a fee-for-service model practice in number of visits in a given day. So instead of seeing 20 patients a day, we would be seeing about 14 patients a day. And we could block out time to do phone calls, which are usually shorter because there's not screening in time and other things that happen in the office that take more time away from the visit. And we also would use secure messaging with patients, and even our staff could handle a lot of patient questions, like our triage nurse, without having to go to the provider for some simple questions. The other thing we did was lengthening the visits, and this is where it was really remarkable to our practitioners how much better their days felt when they had more time face-to-face with their patients and really getting their story down, having time to document what they needed to document in the medical record, no longer documenting in order to get paid by an insurance plan, but documenting for what a patient record ought to have in it to do good care. And we were also able to develop protocols for team members to help triage patients more appropriately, to really get the people in the office that they needed to be seen, and patients who could be managed over the phone. We would provide phone advice and save them a trip in if it was something simple like a cold or viral infection, things like that, which we are currently paid for seeing, which oftentimes don't need to be seen in the clinic. And one of the advantages of this model, too, is you can actually develop you're incentivized to do in-office procedures if you care about the total cost of care. And a good example of this is a lot of our dermatology procedures, for instance. If we do those procedures in our office, the charges that we would have in a fee-for-service model are much lower than what a dermatologist would charge. And it's not uncommon for me to do procedures on a daily basis in the clinic where we're probably charging about half to two-thirds of what a specialist may charge for the same procedure. And that allows us to lower the total cost of care significantly if we're not having to refer those patients out. When we talk about this model, we think about about the concept of advanced primary care. And there's been a problem with our current strained primary care system in that many practices, because of the incentives of fee-for-service, have not gotten used to managing patients as much, and they send patients out for problems that they should be managing on their own. I have seen many patients who've come out of practices in other parts of the country who move out west, where we are kind of more, I guess we're more commonly expected to manage more things because of the rural nature of our practices. But I've had patients with straightforward hypertension who are seeing cardiologists twice a year for the management of their hypertension. And these are people on simple medications without any complications of hypertension, just simple management of hypertension. And same thing with type 2 diabetes. Patients seeing endocrinologists for type 2 diabetes when they're well controlled and have no complications of their diabetes. And those types of referrals are just not something that you would do in advanced primary care. You would manage those patients on your own. You have the time to do it with longer visits, and they really don't require specialty input unless they have complications that are difficult to manage for that with their conditions that they have. So advanced primary care does put the onus on the primary care providers to do more direct management for common and complex medical conditions. And this is also true for acute care. Advanced primary care practitioners actually can take care of a large number, about 90% of the acute and chronic conditions that happen without referral. Advanced primary care also includes population health management. And this is a new area for many people in primary care, and that is being able to get data on your patients. Our electronic health records are finally now much more able to provide good population health data for us in managing our patients who are at risk. And using that population health data to identify who your high-risk patients are by name, and then developing systems within your team to contact those patients to make sure they're getting in for their follow-up appointments and that they're taking their medications, they're picking them up at the pharmacy, when you write new prescriptions, those types of activities that in the past were really not part of the fee-for-service practice at all. The integration of behavioral health and care coordination with case management nurses is another key aspect of advanced primary care. And in our clinic in Seattle, we had 2 embedded psychologists on our staff that when I would see a patient who had a significant psychological issue going on that needed some intervention, I could page my psychologist who would come down, meet the patient in the room with me, and we would do a warm handoff between the clinical provider and the psychologist, which really improved the follow-up with those patients with the psychologist. And sometimes just a handful of visits would be what that patient would need. And having that handoff really made that seamless. And then the care coordination work that care coordination nurses do is incredibly important because the highest risk patients that we have often have very, very dysfunctional lives and difficult challenges both psychologically and socially. And these nurses spend time on the phone with them. They'll meet them in the clinic. They may do home visits. Really work with them to stay on their treatment plans in order to maintain their health as best as possible. So yes, and then the last point about advanced primary care is that it is accountable for access and also referral management. And when I think about access, the issue is that we have to have a system that allows patients to get in when they need to get in. And if you have an overbooked clinic with every appointment full and you're seeing 20 patients a day, it is very difficult to add on patients to that schedule. Whereas if you have 14 or 12 patients booked every day and you have flexibility in your time, you can add on several patients quite easily if necessary for more urgent appointments. And that access means they're not going to the ER, they're not running to an urgent care center, they're not going outside of your system of care when they can see their primary care provider, which is the best place for them to be when they have an issue that arises urgently. And then for specialty referrals too, we can track in advanced primary care practice, we can track what kind of referrals we're making. And if we are referring out patients to a particular specialist who typically manages the patient well and efficiently, then we will keep directing our referrals to that specialist. Whereas if the specialist tends to overdo too many tests, or they seem to be taking a shotgun approach to their care, we will send them somewhere else. The other thing about advanced primary care and comprehensive payment models is that we can create smart incentives. There is so much opportunity to redefine how we incentivize good health care. And the way I like to think about it is making incentives that are based on goals of the patients, the payer, and the practice, all three. A good primary care practice actually would have a patient representation committee that would allow patients and providers to work together on how the practice delivers care to that population. And in that type of environment, you can help define what are the things that matter to the patients the most. And usually, typically, that's access. That they want to be able to get in and see their provider when they need to see their provider. And they also don't want to waste their time. They don't want to be sent off to appointments that they don't need outside the clinic. And they really want to have the right care done at the right time. And obviously, this is something that the payer and the provider all want as well. So finding ways to incentivize and creating those incentives jointly is really a smart way to go moving forward for value-based incentives. We all want healthier patients at a lower cost with a practice model that's sustainable and makes sense. And talking to many of the physicians who've worked in comprehensive payment models already, that's one of the things that I hear over and over from them is they feel like the work they're doing makes much more sense to them and it feels better every day than the fee-for-service model where they felt like they were just running and trying to keep up with the volume with really not as much attention to the outcomes of what they were doing. And as we think about these incentives in the future, I think we need to expect that our incentives may be very different than the typical incentives that we often see. One of the interesting things I've seen with our practice in Seattle was that we were being judged by one of the insurance plans that was paying us in a comprehensive way by the reduction of our ER visits and hospitalizations. And while that is a very good thing, and it does, if you reduce that, you do save a lot of money, but the biggest savings that we had was actually not in that area. The biggest savings that we had were in specialty visits that were reduced, and also ancillary studies that were reduced, especially radiology studies. We were doing less x-rays, less MRIs, less CT scans, because really there was more accuracy in the diagnosis that we were making, and we could often skip the wrong test and do the right test because we were not being bound by some of the pre-authorization issues that those insurance plans wanted to use with other fee-for-service practices. So those incentives really can change a lot if you are in a comprehensive payment model. It's really good to look around the world and you look at good healthcare, and I think this is something that we have not done very well in our country at all, is to learn from others who are providing outstanding primary care. In Scandinavia, especially in Norway and Denmark, where they have very similar healthcare systems, they place a high value and emphasis on primary care. 40 to 50% of all their physicians in the country are family physicians. In this country, it's about 12 to 15% in most regions. A greater proportion of healthcare dollars invested in primary care. In these countries, they spend 10 to 12% of the total cost of care that is directed towards the primary care practices and teams. In their models, they have a primary care clinic physician supported by a nurse practitioner and nursing support staff that have assignments to help them with their daily work, but also with population health management and preventative services. Some countries in Europe actually have an entire separate entity that manages preventative services for their patients. The patients receive information and phone calls from the service to remind them to get their colonoscopy, their mammogram. It's completely taken out of the primary care office, and the primary care office is informed about those tests being done, but the responsibility to track it down and get it done is actually placed on a different organization entirely that's tied to the health system. But the results are, in these countries, and both Denmark and Norway are quite expensive places to live, but yet they have 40 to 50% lower cost of care per capita for all their health care, and they have better health care outcomes. They have a far less reliance on specialty care, and many more issues are dealt with at the primary care level. And of course, with that cost savings, they're able to have universal access to health care for all of their citizens. So these leaders in change, like the Northern European systems, are quite important. We're also seeing here in our country the direct primary care model, which it allows for fixed payments per month going to a practice, which is typically right now an individual market, although there are certainly businesses that are taking advantage of this model now. But doing this type of model is a way that we're going to see, I think, more pressure on the system to change the payment model that we have for all of primary care. I think that the fact that your organization is looking at how do we do this type of payment model for direct primary care or comprehensive payment for primary care is a key driver of change that's going to happen in the future. Obviously, some employers are looking at on-site clinics. Everybody's looking for after-hours care, urgent care. Many employers are looking at direct primary care contracting, and this is going to drive change and put pressure on other payers, including Medicare, Medicaid, and other insurance plans, to think about primary care differently. This just came out back at the end of June, but Highmark, which is a Blue Cross company in Pennsylvania, has saved $260 million through a value-based payment program to primary care providers. And this type of savings is something that I think we would all love to see. The percentages of how much they saved was significant, and as you can see in just the very top part of the article here, They had 11% fewer emergency room visits, 16% decrease in admissions. But I would also, if you look more closely at these savings, you would see a lot more savings with other parts of the cost structure, such as ancillary studies and specialty referrals as well with this kind of savings. But there are places in the country that are experimenting with this and seeing big savings when they actually have large enough populations to really assess that. One of the things, one of the comments I've made to a number of leaders as we've talked about how to think about healthcare system change, and it's this quote here: "Whoever has the best primary care wins." And this brings up a couple issues. First of all, there's a shortage of primary care overall. When you have a model of care where you are stressing the primary care system, there's been a lot of disincentives to going into primary care if you're a physician in training. And even our nurse practitioner colleagues, many of them have been incentivized to go work for a specialist, maybe in a hospital practice where they have a very limited scope of practice. They do the same thing every day, taking care of patients and admitting them to the clinic or admitting them to the hospital for the cardiologist, not really using all their skill set that they have. But because they get paid well and it's fairly simple practice model for them, they do that, as opposed to going to primary care where it's much more challenging work with a broad spectrum of care that they'll need to provide. So there's been a disincentive to go into primary care specialties across medicine, and this has created the shortage that we see now. So not only is there a shortage of primary care, but there's also a severe shortage of what I would call high-value primary care practices. Because of the disincentives to do comprehensive care in your practice, there are very few practices in many parts of the country that are actually providing high-value care, where they're doing a broad spectrum of care and complex care management. And so we have to up the game of some of these practices, and that's one of the things that you will have to do in your due diligence in finding a practice model to work with, is that you want to be sure that you're partnering with practices that are able and used to providing comprehensive primary care and have the capacity to do that. And the other question, I think, for a lot of payers is, how do you capture the best groups to take care of your own population? I can imagine many markets, I've seen this already, where there are many markets where you may have a medical group that really is providing high quality care, and if a payer captures that group's population capacity, then other payers have nowhere else to go. They don't have they won't have access to that group. And it is going to be a competition for who can get the best primary care. And so the sooner you move on this, the better off you're going to be for your patient population that you have to take care of in getting the best care you can get from them in your community. I mentioned direct primary care, and I want to just touch back on this again, that this has been a game changer for many practices in the country, where they're using a comprehensive primary care payment model. It's a form of this where usually it's a subscription basis, where either the individual or a payer like an employer pays a monthly payment to the practice to manage their care. It typically increases the investment in primary care up to about 10 to 15% of the total cost of care going into that practice. When that investment is made in a direct primary care practice, the total cost of care typically drops, as I said, between 15 to 30%. One of the companies in Seattle enrolled 2,500 employees and their families into one of our direct primary care practices there. And they had, in the first year, even before they actually got their population health systems really fully in place, and their chronic disease management systems, which takes a while to get people kind of enrolled and put into those high-risk pools. Even before they did all that work with that population, the first year they saved 30% of healthcare dollar for that company, just because of having good access, longer visits, more accurate diagnosis, less reliance on specialty referrals, and actually more efficient specialty referrals that practice set up. So those changes can happen very, very rapidly. It doesn't take 5 years to get a 30% reduction. It often only takes 1 year. In the practice that I had in Ballard, we had a 25% reduction in the first year of total cost of care. So these practices are starting to work more and more with employers, and I think what the advantage of doing this is it does actually cut out the insurance company and their 18 to 20% overhead when you directly contract with a practice, so that right there provides a significant savings right up front with claims management. But you also are providing those resources to the practice instead of to the insurance plan, which makes a dramatic difference in their ability to take care of your patients. So the common denominator we've seen with these practices in direct primary care is that there is a significant increase in face-to-face time. Most of these practices have 30-minute appointments, if not longer, especially the practices that I've seen many times, for new patients who come into the practice, they have 1-hour appointments to work with the care team, really get their history sorted out and figured out, and have their care plans designed for them for that following year. When you have that kind of time, you can actually get those things done. One of the projects that we've worked on with Family Medicine for America's Health is to develop a comprehensive primary care calculator, and this is on the website fmahealth.org. And this calculator tool is something that we work with a actuarial firm to help develop. And we looked at a conceptual framework where we were looking at taking 10 to 12% of the healthcare dollar. How would you divide this 10 to 12% out into 4 components to pay a practice for managing a population? And there's 4 components that we thought were appropriate for this. One was to pay for the population. So taking a case mix risk index for your population and figuring out how sick are the people that are coming into this practice, and paying for that. Higher risk patients, you'd be paid a little bit more than you would for lower risk patients. You can also use education income adjustments, because we do know that social determinants of health are quite important, and the better educated your population, the lower their healthcare costs tend to be. We also felt it was important to pay for quality, looking at quality metrics and outcomes that really matter for patients are an important component of this payment calculator. You have to have a payment for access and utilization. We want to be sure that we're paying practices to provide a good patient experience, that they feel like they're being well cared for and they have good access to their primary care provider. The utilization piece would be looking at referrals. How do we, how well is the practice managing their referrals and imaging costs? And then also being paid for the scope of procedures that you do. You can imagine that if there's a practice that does very few procedures, they're going to be referring out a lot of patients for those, whereas if you have a practice that's doing a lot of procedures, those costs are kept internal, so incentivizing that with some additional payment for those procedures is important. And then finally, payment for infrastructure. Part of this payment model does need to include paying for the case management team, the psychologist, those types of add-ons that you may want to, you would need to have in the comprehensive practice model to cover those costs. So this calculator tool is available in FMA Health, and I think it's really worth having your organization look at that tool as you're working out a payment model for a primary care practice you may partner with. And both the practice and the payer can use the tool to come up with a negotiated settlement what those costs should be. But typically, we're finding that an average per member per month payment between $60 and $100, somewhere in that range, depending on the case risk index for that population, is an adequate amount to cover the needs of the primary care practice to be successful in lowering the total cost of care. And there's other things to consider. I mean, if a practice that you're working with does not have behavioral health as part of their practice, that's going to cost something to obviously add those kinds of people onto their staff, and they may need to have space as well for for those providers. But behavioral health has a significant cost reduction, and if you have that embedded in your practice. And so we do need to look at how we can get psychologists or masters of social work counselors into practices so that they can help manage patients with significant psychiatric or psychological issues that are going on. Larger practices may be able to hire a pharmacist to help manage their medication refills and surveillance for patients who have high-risk medications, and they can bring a significant value add addition as well. And I think in a small practice, it would be hard to have enough work for a single pharmacist to do, but in a larger group practice or a larger population, say, 5 or 10,000 patients, a pharmacist could be an important addition to that team. One of the things that we've discussed a lot within our medical group is the idea of having physical trainers or physical therapists on salary. Currently, the physical therapy model that we have in this country is fee-for-service, and they are paid by how many visits that they do with a patient, not whether or not the patient needs 20 visits or 10 visits. Perhaps they may only need 5 visits to learn the exercises they need to do in order to improve their musculoskeletal complaints. But musculoskeletal pain is a significant problem in our culture, and having good physical therapists or trainers to help patients do the right exercises and to improve those symptoms is really a key part of the kind of care we need to be delivering at the primary care level. So having space and capacity to have those types of employees on your team would be really important. So as you think about the comprehensive payment models and the calculator tool that we have, adding on these additional services could be a very important aspect of reducing the total cost of care. Okay, so just to summarize, we really have ample evidence now that high-value, broad-scope primary care improves the cost of care, and improves health, and we need to find ways now within our system to make that possible by changing the way we pay for primary care. So eliminating fee-for-service and all of its related incentives is essential to lowering costs, and the comprehensive payment model for primary care really allows for aligning payment and care delivery to achieve better care outcomes. And the next time we get together for the next webinar, I'll be talking about the 7 healthy habits of advanced primary care, and it'll be focused on what to look for in a practice partner that you're partnering with to see, are they going to be able to achieve high-value care with the model that they're currently delivering. So now I'll put it back to our hosts and take any questions you may have.
Great. So we have a couple of questions so far. Let's see, we'll start with the first one. Dr. Tuggy, you mentioned in your presentation sort of anecdotally about providers being interested in practicing in this more comprehensive model as opposed to the fee-for-service model. But are you aware of anything that is a little more systematic or a little more of a rigorous understanding of providers' desire to practice in this type of a model, and what that might mean for the likelihood or the ability to set something like this up?
Yeah, so there's a high degree of burnout in primary care, and when this is actually a major issue within family medicine in our academy, is the amount of providers who feel burned out is at an all-time high. And the reason is when you ask those providers why does they feel that way, it's because of the whole throughput pressure and also dissatisfaction with the way they're practicing. When we have had opportunities to, when a new, like a direct primary care practice opened in Seattle where I worked, 90% of my graduates that year went to work for that company in the training program that I had. It was, the draw to work in a direct primary care model where they can spend more time with patients, feel like they can provide better care and have better alignment of their incentives is huge. So that is it has been my experience around multiple markets now that we've looked at with our FMA health projects, that the incentives to join those practices are very high for physicians who are in fee-for-service practices. And then the other part of it is that young physicians who are coming out of practice have heard about this, and they are incredibly interested in this model, and they want to find positions in this kind of model. I think some of our older physicians, people in my generation who are in their 50s, who are getting close to retirement, they've kind of figured out how to game the system, and they may feel like they can get by for the next 5 years. But it's interesting. I was just at a direct primary care conference in Indianapolis, and probably half the room was over age 50. People who have actually been in practice for a long time and still were willing to leave fee-for-service and move in direct primary care because they were so tired of the rat race. So it's certainly not just a few physicians who feel like changing the model is important. Most physicians in primary care, if you sit them down and ask them would they be willing to change this model, are highly in favor of it.
Great. All right, so sounds like providers, there would be interested providers in doing this. Seems like payers are interested in reducing costs. So what's the biggest hurdle in making the shift over to this type of model? Are employees, there's going to be a lot of questions in here actually. Are employees willing to change their primary care providers if they need to do so to get into this model? And can you comment at all on the differences between perhaps an urban setting versus a rural setting?
Okay. Yeah, so I think the challenge, there is certainly a challenge of getting people to change their primary care provider, but when people look at patient behavior around who they see, many times it doesn't take much for a person to change providers, which is actually a sad statement. If there's not an element of trust, or if the patient hasn't had a good experience at a practice, they are very readily will leave that practice. If they have been there a long time, those people have a much harder time changing over. So who your primary care practices that you partner with is going to be very important in the community. You do want to work with a practice that has a solid reputation, and ideally, if your employees are already going to several practices, there are ways that you can contract with those practices to take care of your employees on a comprehensive payment model, as long as those practices are willing to do that. And I think that as far as the biggest barrier goes, obviously there's two components. One is having a payer who's willing to pay that way, but the second thing is having a practice understand what this model is going to do for them. And that's been a lot of my work, as I've worked with practices that have not made this conversion, that are interested in looking at it, not sure how it's going to work. But once you work out the finances and work out the way that they're going to be paid, so it's clear to them how they're going to be paid, when they understand what that shift is like in the incentives, and it makes so much more sense to them, universally people have been very favorable about making the transition. And so that has really been a driver for kind of excitement about this model. Is once they understand what it's going to do for their day-to-day work and how it's going to provide them with more resources, because you're taking a practice that's used to getting 5% healthcare dollar, you give them 10% healthcare dollar, they can suddenly afford to have case management nurses. They can actually have a psychologist on their staff, and it completely makes sense to them to have those people to do the work that they want to do, and they become quite enthusiastic about it once they see that model. But it is a culture change, and I think that primary care practices have to be in the mindset of it, that they want to change, that they want to disrupt the way that they're doing things and make it better. And that would be one of the key things to look for in a partner.
Great. I think, so we have a bunch of questions that have come in. I think we have time for about one more. Tierney, do you want to read off another question?
Yeah. Excuse me. How are providers managing the balance between their FSS clients and their CPCP clients? with the assumption that providers are not changing the entire practice to accept only the CPCP clients.
Yeah, so this is happening actually in a lot of different practices where there's where some practices have managed care patients. Like in our medical group that I currently work in right now, we have 18% of our practice is managed care, and the other 82% is fee for service. And you really have to have about 30% of your practice on a comprehensive payment model in order to really implement the changes easily, like lengthening appointment times to more appropriate lengths. So if a practice is trying to do a blended model, it does create a lot of tension. And that's why if I was looking to set up a partnership with a primary care practice, I would want to do as much as I can to make sure that that practice has at least half their population would be patients who are on a comprehensive payment model, because that would allow them to create the infrastructure to bridge the time between where we're at now to where we actually have more comprehensive payment models from other payers like insurance plans or Medicare and Medicaid. It is a problem if you don't have enough patients in your practice that are on the comprehensive payment model in order to actually make the transition to longer appointments and having the right staffing.
Great. We just have one more. When you open a direct primary care clinic, have you seen any pushback from health plan systems who are currently serving those patients?
So the clinic that we opened in Seattle, we actually had 2 insurance plans that we were able to negotiate with to pay us on a monthly comprehensive payment model. For them, I think it was a curiosity. They were willing to try it in order to see, like, what would this actually do? This was actually 9 years ago. This was a long time ago when we started this process. And they were very resistant to increasing our payment. Obviously they were used to paying us this 5%. We said we need 10% of the healthcare dollar, and so that was a bit of a negotiation, but we were successful in doing that. The interesting thing was, though, after the first year, when we had this 25% cost reduction, they were actually incredibly shocked. And so, but what was interesting too is they weren't interested in expanding it to other clinics, because when you reduce the total cost of care by that much, it's actually a threat to the current model. It's actually a threat to their revenue stream. If suddenly the total cost of care went down by 25 or 30%, then that means that the money that they're handling goes down by 30%, and their commission on that actually decreases. So it is a tension with other payers. Bypassing the insurance plans is going to create some tension. However, it's not our job to keep them employed. Our job is to take care of patients, and so it does create a tension there for sure.
So we've had a great number of questions that come in. There's obviously a great deal of interest in this, a desire to learn more. In terms of kind of the next steps on this topic and what the Alliance is doing related to the topics, watch for a follow-up email that will include a registration link for Part 2 in this specific webinar series that we're having. The email will also include a link to the presentation so that you're able to access that again, or if you want to share that with anybody else. It will also include a way for you to sign up for updates as the Alliance continues to share information about this topic, and also share information about what the Alliance in particular might be doing related to this topic. Primary care is definitely an area that we are focusing on, and there may be initiatives that we have related to that. And if you sign up for the updates, you'll be some of the first to know about those in the future. So with that, I just want to give a special thanks to Dr. Tuggy for his time and his knowledge. We'll encourage you all to sign up for the second webinar. Pass along to anybody else who you think might be interested in this. And thank you very much for your attendance, and have a wonderful day.